So my name is Charlotte Quinn. Um, this patient that I'm presenting a case of Heyde syndrome, this is actually a patient that I saw during my rotation on the cardiology wards. So the patient, so it's Heyde syndrome, really syndrome of GI bleeding from angiodysplasia. Um, Usually this is seen in the presence of aortic stenosis. Typically it results from hemodynamic changes, increased shear forces in the circulation that lead to cleavage of von Willebrand large multimers. Typically this is seen with aortic stenosis. Rarely it can be seen with other cardiac disorders that have increased turbulent flow, such as severe mitral regurgitation, hypertrophic cardiomyopathy, and complications with ventricular assist devices. And so in this case, we had a patient who had severe mitral regurgitation who presented as a Heyde syndrome. So this gentleman is a 63-year-old. He has a history of mitral valve prolapse, had severe regurgitation associated with his MR or with his mitral valve prolapse. 4 months prior to his presentation, he had undergone a mitral valve annuloplasty and had a bioprosthetic valve placed. During this presentation, he presented with 3 days of dyspnea and dizziness. He also reported 1 week of melena. When he did his vital signs showed that his blood pressures had been ranging on the high side from 160s to 190s. And on physical exam, he was noted to have scleral icterus, as well as a harsh systolic murmur that was best heard at the left lower sternal border. On the workup that we got for him, his hemoglobin was found to be severely low at 5.1. He had undetectable haptoglobin, and his lactate dehydrogenase and total bilirubin were both pretty elevated. So at this point, since his labs were consistent with hemolytic anemia, we did discuss this case with hematology. We ended up getting a peripheral smear on this gentleman, and we noted the presence of schistocytes. And so we followed that up with a von Willebrand panel that showed reduced levels of the highest molecular weight von Willebrand factors. And this was suggestive of acquired von Willebrand syndrome. So with all of these things taken into account, we were pretty concerned that his valve was actually the cause of all of his issues. And so we did a transesophageal echo on him, which did confirm that he had severe mitral regurg and an elevated prosthetic valve gradient. And this can be seen in the images in the center, the figure A where he has severe regurgitation, and in figure B, the cardiologist who did his procedure, his TEE, calculated his PISA, which is basically just a measure of his effective regurgitant outflow, effective regurgitant orifice, which showed a pretty severe mitral regurgitation. So really, the higher the PISA, the more severe his regurgitation, which his was greater than 1. So we initially admitted this gentleman to the CICU for medical stabilization. He received IV vasodilators for blood pressure control, and we did give him blood products to correct his anemia. We had a discussion at our multidisciplinary team meeting, and he ultimately underwent a repeat open surgical mitral valve replacement. And postoperatively, he had resolution both of his hemolytic anemia and his gastrointestinal bleeding. So really, for us, this case kind of highlights the importance of keeping a high suspicion in patients who have regurgitant or any valvular disorder that has increased turbulent flow. For him, his mitral regurgitation, as well as his von Willebrand factor and his gastrointestinal bleeding, did confirm that he had the Heyde syndrome. So while this is typically associated with aortic stenosis, it's important to keep in mind that other valvular disorders with high regurgitant flow or increased turbulent flow can also give you this syndrome.